welcome to the podcast. I am so excited to have you today.
Thanks, Tara. It's lovely being here and chatting with you on gut things.
Yes, all things gut.
Yes, all things gut.
Yeah, it's going to be good because you are definitely an inspiration to me. I have been learning from you for a while now. It's been a few years. I've done a lot of your small courses, and now obviously I'm doing the advanced certification, which is just incredible. A wonderful certification, which we can chat about.
Thank you. Yes.
Yeah.
Thank
Yeah.
you.
You have been instrumental in some changes that I have made. I've been sort of talking a little bit to my community and on the podcast a bit about changes in the approach that I've been taking as a practitioner to my clients' gut health. So I'm excited to dive in. So,
Yes.
with all that in
Let's
mind,
dive.
let's dive. Let's
Indeed.
start with why gut health? Why is it so important? Why should people even care about gut health?
Yeah, and I think for people that have obvious gut discomfort or bloating, distension, gut pains, diarrhea, constipation, they care because they have symptoms that they can clearly see are gut related or heartburn, for example. And there's a large proportion of people who in the Western nations who actually tick those boxes and would have one of those things or reflux, so it's like they're obviously getting symptoms from a gut that's not working the way that it should. But what we have learned, I would say, in the last 20 to 30 years is that what's happening in the gut doesn't just affect what happens in the gut. It actually impacts every other body system. And I think really there was some pretty I'm trying to think back when that research sort of really started changing people's minds. And maybe the first study published in 1999 where they gave probiotics to pregnant women to prevent eczema in the child. And that was pretty mind-blowing at the time, because at that point probiotics were just for gut things.
Yeah, right.
For us now, like, of course we use probiotics for this and this, but at the time you only use probiotics for these gut related conditions. You would never think about using it for anything outside that. That was a game changer when that was published. It's like, whoa, look at that. We can change how the immune system functions in the next generation by having them exposed to this probiotic, and arguably for life, changes how their immune system actually is functioning. And then there are studies in the early 2000s, mid 2000s, where I think the pivotal one where they are able to induce or transmit obesity. They could take a poo transplant from an obese mouse, I think it was, and give it to these thin mice, and they would get obese from that, despite no change in calorie input or output. They were exercising less or eating more. They weren't. They just gained weight in the same diet. They became grossly obese just from the poo transplant. That was another one of the studies that was a game changer. It's like, whoa, what we're doing to the gut microbiome alters how your metabolism works. And since then, there's been a lot more research that's been done that's linking, with depression, anxiety, Alzheimer's disease, Parkinson's, multiple sclerosis, fatty liver, endometriosis, polycystic ovarian syndrome, osteoporosis, high blood pressure, metabolic syndrome. All these things are related to gut microbiome. That's what's been pretty amazing to see in the last 20 years. It's all these things and we've definitely gone from that correlative research where, like, oh, we study people with the disease and people without, and look at their microbiome and go, oh, look, they're different. Which is always like interesting, but does that matter? Or is it different because the disease causes a change? And we really worked out is no, it's the microbiome that causes the disease. Right. And again, we can take a poo transplant from someone with high blood pressure, give it to mice, and they get high blood pressure, or to people and they get high blood pressure, and vice versa. We can reduce people's blood pressure just from doing a poo transplant. You're like, amazing. Even someone for me who spent nearly 25 years now delving into gut microbiome, I did not ever think high blood pressure would be a transmissible disease via poo transplants.
That's crazy.
Yeah, it really is. And I think because when we talk about all the disease I listed there, it's like that's a lot of the population right there. And even we've delved into the aging microbiome and how essentially the microbiome is a driver of the aging process, or it slows the aging process too. And all of us are obviously aging, so it's related to us in that everyone's lives in that respect too. Yeah, so it is a really huge pivotal factor in our health and well-being. And I think the microbiome is a key component of that, but also is your gut integrity, and also I would say transit time too, in that you want to make sure that things are moving well. It's when we have a gut that's not moving well, even if you have some of the other things in the right place in terms of microbiota composition, in terms of lack of gut leakiness, if things transit time is slow, you're going to have a range of health problems associated just from that.
Let's talk about that, because a lot of people are going to be sitting here thinking, well, I go to the bathroom every single day, so I have good transit time. I'm good. I can tick that box off. And so a few things you said, it's microbial composition in the gut, it's whether or not your gut is leaky, which is also something to touch on, and the transit time. So in regards to the transit time, why don't you explain a little bit about why you can be going to the bathroom every day, but you actually can still have slow transit time? And what does that mean? And what transit time do we want to have?
Yeah, a great question, and great point to differentiate too, because I think there's a lot of people there who think, I empty my bowels once a day, therefore it must be fine.
Yeah.
And even I had that a bit too for the first part of my practicing career too. Yeah, and you might go, okay, there's the poo scale called the Bristol Stool Chart or Bristol Stool Scale. You're welcome to Google it if you don't. Your listeners don't know it. It's got 7 different types of poo on there, and people kind of make the assumption if it's in the middle, so somewhere, and they're pooing once a day, they're fine transit time wise. It's just not true. That's the thing, is when you get people to do, and luckily for us, this is you can do this in a hospital setting in a very like high tech way, or you can do this at home in a very low tech way. And I choose the at home, low tech, no cost way to assess someone's bowel transit time with every single patient I see and have for a number of years now. And that's eating some corn on the cob or some canned corn, black quinoa, black sesame seeds, kind of, and trying not to chew all that well. Like, don't choke on them, but don't chew them particularly well, because you want to be able to see them in your poo. That's the point. And you'd write down exactly when you ate them, and you write down when you first see them come out and when they finish coming out in your stools. And when I started implementing that with every single patient, I had those patients who every single day never missed a day ever. And type 4 on that Bristol Stool Scale, so people with like, perfect poo, 10 days was when she first saw the corn pop
Incredible.
out the other end.
Yeah.
Now she had fatigue,
Yeah.
brain fog, bloating, distension, and symptoms I would tend to associate with slower transit time. But you would not have get that if you just looked at the stool form, which was the perfect 4, and the frequency of bowel movements. Yeah. Whereas other people that might be emptying their bowels once a day, they will see the corn after 16 hours. So it can vary so dramatically. And this is why doing that test, I think, is imperative to work that out. And that's why every single one of my patients does that test at baseline. So we have that knowledge to work with, because when you do have stuff sitting in your colon for long periods of time, it's what naturopaths have always referred to as bowel toxemia. And I think it's a very apt term, because it's exactly that. You're absorbing bacterial toxins through your colon or large intestinal wall, but also environmental toxins too, and hormones too, that your body's trying to get rid of. It's like when the main way your body detoxes is through bile, which goes into your poo and is supposed to be pooed out. But when it doesn't get pooed out, or if it's sitting there for long periods of time, a lot of those compounds get re-released. We call it enhanced enterohepatic recycling in the trade, but essentially it's bacteria eat something and re-release that compound, that hormone, that environmental toxin, and you get to get exposed to it a second time and a third time and a fourth time until we actually eventually poo it out.
Now, that makes me think about, aren't there studies on how gut health can be associated with non-alcoholic fatty liver because of this very concept? Is it that, you have to detoxify all these toxins if you're not pooping them out on a regular basis, or if you have slow transit time, those toxins go through to the liver, right? And they burden the liver. Is that right?
And that's the first place where things are detoxed. Yeah. And we know that bacterial toxins, primarily what we're referring to is lipopolysaccharide or endotoxin, which is in the cell wall of all gram-negative bacteria. So generally we're talking about microbiology. We've got gram-positive bacteria, gram-negative bacteria. That's really to do whether they took up a stain by a guy called Gram. Long time ago, he developed a stain to put on to make bacteria visible, but some bacteria worked on, some it didn't. So there's like gram-negative, gram-positive. That's where that comes from. But those gram-negative bacteria they just grow some special stuff in the cell wall. Like we grow hair, we grow nails, they grow endotoxin. It's not meant directly to make us ill. They're not secreting the toxin to harm us directly, but it does.
And
our liver is pretty good at detoxing some of it. In fact,
right.
we've got mechanisms on our intestinal cells to detoxify some of it too. It's just when you have an excess of produced It exceeds what our intestinal cells can deal with, goes into our portal bloodstream, goes to the liver. The liver will filter out most of that quite
Yeah.
effectively for a while.
Mhm.
But what it doesn't will cause inflammation and damage in the liver, and then
Mhm.
it floods your system. And this is where we're seeing this, say, a lot of the chronic diseases that we see commonly around us in Western nations have a strong endotoxemia driver. Yes,
Yeah.
these bacterial toxins getting through either like slow transit time in your colon, you absorb more of them there too.
Yep.
Yeah, if you got a leaky small bowel, you absorb more of them. So this
Yeah.
is where we have that triad of like a altered gut microbiome, leaky gut, slow colon transit time, which is quite common in Western nations. That's like
Yeah.
horrific in terms of the actual load of bacterial toxins that you're going to be having to deal
Yeah.
with.
Yeah.
And as we touched on before, the liver is quite good at it for a while, and
Yeah.
then it becomes loses that capacity, and that's where we start getting the damage that occurs. And you get endotoxins flooding everywhere. We know it
Yeah.
causes damages the blood-brain barrier. We know it
Yeah.
changes your neurochemistry.
That's right.
When we know that people with Alzheimer's have between 3 and 26 times more endotoxins in their brains than
Wow.
healthy controls.
Wow. Oh gosh, that is such an important piece of information. So anybody who is listening who's constipated, let alone you don't even know what your transit time is,
Yeah,
you really got to get on top of that. Like a lot of
it's
people just
huge.
think constipation's normal. Like I have so many friends and women in my community that, oh yeah, I'm just constipated. It's like, no, this is actually a very big deal. This
It totally is.
could
Totally is.
essentially drive chronic disease. So you
Yeah,
got to get on top of that.
you're spot on, and it does. And there's research showing that now too.
Yeah.
That at one time, I think constipation was seen as a side effect of Parkinson's.
Yeah.
That's reversed, and now
Other way
constipation
around.
is seen as a driver of
Driver.
Parkinson's.
Yeah.
Yeah, and it definitely increases your risk of a range of even heart attacks
Yep.
and overall mortality. Your risk of just
Oh,
dying is
yeah.
increased if you're constipated, and
Oh
that
my
all makes sense when you understand all the extra sort of toxins you're
God.
absorbing with your bowel wall when things move slowly
Yeah,
through that
it
area.
does. It
Yeah.
does make sense. So basically what happens in the gut doesn't it stays in the liver, goes to the liver
Yes,
and
absolutely.
the bloodstream,
Yeah,
right?
that's right.
Okay, so a couple of points there. I want to talk about saturated fat, by the way. So I've written that
Yeah,
down. We've got it because that's something that's important for us to discuss, I think.
yeah,
But before we go there, because you've touched on leaky gut, I think that it has become such a term that's been bandied about in the online health space. But not everybody has a leaky gut, and you can actually
yeah.
have a lot of gut symptoms and not have a leaky gut. So why don't we just touch on leaky gut and why we shouldn't just assume we have a leaky gut. Not everybody has a leaky gut.
Yeah, because even if you look at the medical literature around diseases that are associated with leaky guts, and there's a number from type 2 diabetes, type 1 diabetes, celiac disease is a classic one, but others too.
Mhm,
If you take a group of 100 people with that disease,
mhm.
still it might be 30, 40, 50, 60% of those people will have a leaky gut, but not 100%. Yeah,
Wow.
so if we end up spending all our patients' money and
Yeah,
time and effort on trying to treat something they don't have, obviously
yeah,
that's a major waste, and that money should have been spent on something they do actually have. And that I think is one of the benefits of testing for it, rather than making assumptions around it. Is we get one, whether it's definitely there or not.
mhm,
Two, we get a baseline, and we can go, okay,
mhm,
this is how severe it is now, and we could do follow up tests in 6 months' time and see whether
mhm,
things have moved in the right direction. Now,
mhm.
you may not bother to do that test if they're feeling great and life is wonderful. Like, no,
Yeah.
that's fine. Well, that's probably all good by the sounds of it. But
Mhm.
the thing about leaky gut, if it's very severe and it gets 50% better, it's still leaky. And you're still getting bacterial toxins through there. So 6 months down the line, because it does take surprisingly long time to heal leaky gut for many people.
Mm, mm,
Um, when you start doing pre and post testing protocols, you're like, oh, whoa, it's not after 1 month or 2 months, after
mm.
2 weeks of supplementing. It's like after 6 months is
Yeah,
usually when I would do a follow up test to see what progress we've made or whether it's gone completely.
yeah.
Um, yeah, it takes considerably longer than one would actually necessarily assume. Because I think I had that thing when I first came out of training was like, oh, gut cells regenerate every few days. Therefore,
Mm,
leaky gut must heal up in a few days when you take out whatever the cause is. And that's not
mhm.
true. That's
Not
not
true.
what reality is. It's just like
Yeah.
it's really can be slow moving, even when you remove the causative agent. Kids heal up more quickly in general, and that's the case too with leaky gut. But
Yeah.
you're looking at a 6 month sort of protocol
Mhm.
before doing a retest, and if they don't have that condition, that's sort of 6 months wasted that could have been spent
Yeah.
elsewhere.
Yeah, good point. True healing really takes time. And I think that a lot of people don't realize. And it's kind of frustrating sometimes to us clinicians, I think, because we know what's possible. We know they can feel better. But if they're trying to feel better in a couple of weeks or a month or two, they're going to miss out. I often say, you don't walk, and I don't know who said this, but I've stolen it. You don't walk 10 miles into the woods to walk out in 5. You got to stick with it and be patient, because true healing is really possible, but you got to be patient.
Yeah, and typically the longer you've been unwell, the
Yeah.
longer it takes to get better. I mean,
Takes.
I think that
Exactly.
rule tends to come through. There are always exceptions to that, but I think in general
Yeah.
that is a true aphorism. Like if someone has just taken a medication like a non-steroidal anti-inflammatory drug that caused
Mhm.
their gut to be leaky for
Mhm.
2 weeks, otherwise it was fine. That's
Mhm.
not going to take 6 months to heal.
Sure.
Yeah, but if you've had leaky gut for years,
Yeah.
then yes, it's going to take a long time to
Yeah.
heal up.
Yeah, absolutely.
Yeah.
So just a quick question then. In your experience, not everybody who has an autoimmune disease then has leaky gut. Is that correct? Correct?
At least at the time that we're potentially working with them, and that might be different at 2 years in the past or 5 years in the past.
Yeah,
When that
right.
was initially diagnosed or that disease process evolved, it may well have been leaky at that point. Yeah.
Okay.
And whereas when we're working with them right now, it may not be.
It may not
Yeah.
be.
I mean,
Okay.
I think I can understand the reason behind just making that assumption with autoimmune disease, because there is a strong correlative link with the research. But when you go into the fine nitty gritty of those links, there's still a lot of people who don't seem to have it at that time, and it still
Mhm.
means that your patient's money is better spent on another thing they need help
Yeah,
with, that rather than we're
absolutely.
trying to treat a leaky gut that they don't have at
Yeah,
this
absolutely.
point. Yeah.
So let's talk about okay, why don't we talk about what are the drivers of poor gut health? So maybe antibiotics would be a good topic. Saturated fat would be a really good topic because of the keto and the carnivore craze that's going
Yeah.
on.
Yeah. Yeah.
But maybe we can just touch on what contributes to poor gut health.
The big question. There's a lot of
There's a lot
answers
of
to
things.
that because of living in Western nations, we're
Yeah.
exposed to a lot of things that
Yeah.
cause either gut integrity harm or microbiome harm.
Yeah.
Yeah, and you're spot on. Antibiotics are definitely the biggest driver of microbiome harm. They're
Yeah.
able to do dramatic shifts within days.
Mm.
Like absolutely massive shifts in composition and irretrievable changes too. I think
Mm.
that's the thing that's important for people to note, that it's not like you can take a course of antibiotics and it'll go, and then 4 weeks later it'll be back to normal. It's like, no, it'll be normal-ish
Mm.
typically after 4 weeks. But we can look at the research. It's like a study published in Gut a couple of years ago that showed 9 species permanently lost from a single course of IV
Oh my
antibiotics. It wasn't
goodness.
orally, it was IV,
Okay.
and 9 species gone.
Jeez.
Yeah.
It's terrible.
So if we think about how that might add up, so our courses, with antibiotics over our lifetime, the impact on our diversity of our ecosystem, our richness is obviously pretty marked from that. And I grew up in the 1970s, and man, they were given antibiotics for everything. Oh, you've got a sniffle or a cough,
That's
boom,
right.
boom, boom. So like
Yeah.
most years, I would have had 3 or 4 courses, I'm sure,
Yeah.
growing up, which was typical at that time point.
Yeah.
And I look at my ecosystem richness now. It's like it suffered from that,
Yeah.
and it's not
Right.
easy to retrieve. You can't just pop a
Yeah.
probiotic pill or take some kefir or some sauerkraut. It's not going to
No.
fix that. They can be useful tools to help in the quicker restoration
Yeah.
to a better to a new set point, but
Mhm.
they can't replace the function of the species that you've lost. I think
Yeah,
that's
right.
the key thing, and nor do they permanently colonize. And that's one of the other myths that's widely promoted, is
Yeah.
that if you wiped out your bifidobacteria, we'll just pop it in a pill and you'll be fine. It's like, no, they don't stay.
They
Yeah,
don't stick around.
that is clear. Like they'll stay for a few days with a good strain, maybe 10 days, but then every single day their population diminishes and then they're
Mm.
gone from
Mm.
that point. So
Mm.
it does bring up that idea of custodianship too, of really, I think people have to be really aware of what you got and how sort of fragile it is. But in some ways it's robust in that it will rebound in some fashion, whether it be chemotherapy, radiotherapy, antibiotics are probably the 3 that cause really acute, dramatic changes.
Yeah.
And yes, it will bounce back, but it will never look quite the same
Yeah, right.
as it did before. Any of those
Just
interventions.
jumping in there, but my daughter recently, as you know, we went to Canada and my daughter got a cat scratch on her eyebrow and
Yeah.
went to the hospital. She had to get a couple of stitches. And I said to my husband, they are probably going to give you prophylactic antibiotics. And I said, just ask the doctor, is it okay if we just wait a couple of days and see,
Yeah.
The doctor said, yes, that's fine. So we actually waited. It was like 4 days in, and then she came to me and she said, "Mummy, I don't feel good." And she did have a fever, and I was like, "Oh crap," like, and I didn't want an infection to, so we ended up giving her some of the antibiotics, but then she wouldn't take them after a few days because they were huge pills, and we had to
Okay.
fly back to Australia, and it was
Yeah.
kind of a blessing in disguise because then I spoke to another doctor when we got the stitches out, and the doctor said that fever was probably unrelated to the
Yeah.
cat scratch. But I was like, damn, because I knew the damage just a
Yeah.
few days of antibiotics could do. But they
Yeah,
are
but
given
you're
out like
balancing
candy,
that out.
though.
Yeah, they totally are. But you've got to balance it out for when it is they do save lives and they do save
Well,
limbs.
that is
So
absolutely
you,
correct.
yeah,
Exactly. That's right. You've got to take them to, they save lives. Absolutely. So they've been a wonderful invention. But, if it wasn't for my knowledge around this, I would have just probably taken the prophylactic antibiotics, told her to take them. So I think
yeah,
we need to also be careful and judicious
yes,
when we're told just to take them. We have to push back and say, well, is it really necessary? And if it is, you take them. And if it's
yeah,
not,
yeah.
you
I
wait.
think it's totally spot on. It's like, is this going to be helpful? Because there's a study published just a few years back where they looked at what patients got if they went to their GP with viral bronchitis.
Right.
80% of them went home with antibiotics for viral lung infection.
Jeez.
And you're like, it isn't going to work for that. And even the rationale that it prevents a secondary bacterial infection is actually not based on evidence either.
Mhm.
But and you're causing harm. And that's one of those ones if you push back, like, do I
Yeah.
really need this for a viral infection? Like,
But also the microbiome impacts the lung, right? We've got a
yes,
gut
yeah,
lung axis. We've got a
totally.
gut
And
everything
and it
axis.
got and we know that immunity dips after antibiotics too.
Yeah.
And that's through the microbiome harm.
Yeah.
It
Yeah.
just happens too. So
So antibiotics, we understand
antibiotics.
them. They're, obviously food and stress and lifestyle impacts the microbiome. Let's talk
Yeah.
about fat.
Yeah, because this one is more controversial these days than it
Yes, it
was
is.
before.
And I'm not
Um,
giving up my butter, by the way. I'm not doing it. I will give up other saturated fat, but I can't give up butter. Don't
I
make me
switched
give
I
up my
switched to olive
butter.
oil like 20 years ago and haven't lost it
Yeah.
back. So
Yeah, I love
yeah.
olive oil, but I don't know, when I have my odd piece of gluten-free toast, olive oil is not the same.
No, it's I would argue better, but you have to get used to it.
Really? I'll
Yeah,
try it.
I drenched it with mine with olive oil.
Okay, I'll give it a go.
That's why I love going traveling in like Italy or something too,
Oh
because
gosh,
like
yeah.
every single table has olive oil, which is I love.
Yeah,
Whereas like in
yes.
France, it says butter. I'm like, I don't want butter.
You don't
Please
want
just give me
butter?
some olive oil, please.
No.
Um, yeah. So and I think, I mean, it is interesting because we know that sunflower oils and seed oils do have some harmful attributes, particularly the high omega-6 content is unhelpful in today's day and age where we're exposed to omega-6 fats, which are pro-inflammatory, way too much. Like we do need them, but we need a small amount, and we have way too much. Yeah, and they can be harmed during the cooking process too. So I think that has led to many people to latch on to saturated fats as ways of around cooking because they don't have omega-6s in them, so they're neutral from omega-3 omega-6 ratio, and they tend to be a bit more stable in the cooking process. But I do want to point out that over the last, I think, 5 years, the research has shown that extra virgin olive oil totally stable to cook with, totally fine. And there's even researchers putting out that we should be cooking more because all the food you cook in it gets healthier. When you cook in olive oil, it soaks up the lovely anti-cancer, anti-inflammatory polyphenols. So when you eat that vegetable, you're actually getting it
Oh, I
all the
didn't know
extra
that.
compounds. Yeah,
That's all I used to cook with, but I didn't know that.
yeah.
That's cool.
Yeah,
Mhm.
it is cool because I think there's that general conception that no, don't cook with extra virgin,
Yeah.
and you try to trace that back, and it comes, I think, partly to this thing around smoke point,
Yes.
and only looking at one thing, smoke point,
Yeah.
not looking at the antioxidant compounds and how that might counterbalance that, which it does, by the way, but
Yeah.
also looking at some of the research that was done in the early 2000s on refined olive oil
Mhm.
that showed it did not cook well. And then people
Right.
took that to mean extra virgin olive oil is the same as refined. Refined is where they take these horrible solvents and pull everything good out of the olive oil
Yeah.
and just leave the fat bit. And yeah, no, that's not good to cook
Sure.
with, and it should not be eaten. But yeah, it's just important to sometimes trace these things back to their origins. But moving probably away just from cooking oils, etc. Too, I think it's important to understand that our microbes, what microbes we grow, depends on what we eat.
Yeah.
Because I think this is sometimes lost. And I think also lost in that there are microbes in our gut that eat bile. The microbes in our gut that eat protein, the microbes in our gut that eat fiber and sugars and oligosaccharides and polyphenols. And, so if we go in a dietary protocol that is higher in fat and higher in protein, you feed microbes that eat protein and eat bile. That's the cause and effect. It's very straightforward. Yeah, it's not complex. It's like what you feed grows. If you don't feed them, they don't grow.
Yeah.
The other aspect too, if you're not feeding fibers or oligosaccharides or polyphenols, those populations of the bacteria all go down. It's just, we know that those that when protein is putrefied or fermented in the gut, it's not a clean process. We get less intestinal gas. Yes, we get a lot less hydrogen being produced.
And that's why a lot of people do these type of diet.
Exactly, because you do have less intestinal gas produced, less hydrogen being produced. That hydrogen that is produced tends to be shunted through to become hydrogen sulfide gas. That is one of the downsides, but that won't necessarily manifest in the short term. Yeah, because hydrogen sulfide gas causes colonic inflammation. It causes leaky gut. It causes what we call visceral hypersensitivity, where the nerves in your gut become hypersensitive to stimuli. So they start reacting to small amounts of gas. And they do these research studies in people with IBS all the time. They have these special balloons that put up your bum. They pop up these balloons, and people with IBS get pain and discomfort when the balloon is this big, whereas normal people it's like this big before the same degree of pain, because the nerves are hypersensitive. And we know that hydrogen sulfide gas makes your nerves hypersensitive. So people get in this cycle where they're like, they cut out these foods because the nerves are already inflamed, and they're like, oh, I'm producing less gas, therefore there's less discomfort and pain associated with eating. But they get more hydrogen sulfide gas being produced, which actually makes the nerves even more sensitive. So they might go, okay, well, I want to bring some fiber back in. And then they feel even worse gut-wise than they did before. So you get this really negative feedback loop, and it can be really tricky to pull out of if you've been in it for long periods of time. But also, it's like, I can see why people kind of lean that way, because it's kind of, they eat this way, their pain goes down, and they just don't understand the longer term complications. And this you see clearly if you do microbiome analysis, like, oh, you're full of hydrogen sulfide gas producers, and you're full of endotoxin releasing bacteria at really high amounts too, because that's the other thing that comes too, because the bacteria that produce the most pro-inflammatory endotoxin like growing at a sort of more neutral pH in the colon, and we achieve that with a higher protein, high fat diets, and more neutral colon pH. We prevent that by having fiber. Like fermentable fibers create short chain fatty acids, which then bring the acid level up and the pH level down, and that suppresses the growth of these sort of more nasty proteobacteria. But so those dietary protocols that have taken out the fiber, fermentable fibers, you are essentially changing the conditions in the colon to make it more inducive to the ones that are problematic, and providing food for them in terms of bile and amino acids too. And so you end up getting this abundance of hydrogen sulfide gas producers, abundance of lipopolysaccharide releasing bacteria in your gut. And then the downside with the saturated fats too is they actually bind to endotoxin and increase their absorption too. So you get like a double whammy there too, because but as I said, some of these things take time to manifest, which is why
that's the key. That's the key point. And that's why these people, they do turn to these diets for symptomatic relief, and they think they're working for me. I feel great, but they don't realize the long-term ramifications and consequences to the microbiome, and ultimately they'll probably end up feeling not so great.
And that's really been my experience of those people. The longer they're on those diets, the harder it is to come back, because your gut is so inflamed and so sort of visceral sensitivity is so high that any sort of gas bubble, even this tiny little gas bubble that big, will be enough to cause you discomfort and pain. So it can be hard. You have to try to build back. And we know that if you starve bacteria out for long enough and just do not feed them for long enough, they will die off too in that process too. So in the short term, the extinction level from starvation is not such a real thing, but with longer term, and we don't know where that cutoff is, and would differ per person too, and whether they took antibiotics during the process. There's a bunch of things that can impact that, because if we're starving off bacteria and taking antimicrobial at the same time, we tend to, their population's already on the edge, and then boom, they can be more easily wiped out as well. But it is an interesting thing that's not widely discussed, the impact of saturated fat on binding to endotoxin and increasing its absorption. So you get more into your bloodstream. I mean, I see this heaps with
Yeah,
my
I'm
patients.
starting to
So
see it. Now that we're running these different types of stool tests, I'm
yeah.
definitely seeing it. I'm seeing it in
Yeah, and
people
that's a
who
pivotal point actually too, because if you're
yeah.
using a stool test, it doesn't allow you to see very much.
Yes.
There's a
So
bunch
let's
of things
talk
you won't see.
let's
So
quickly
that's the
talk
problem.
about testing then. So before we wrap up, why don't we just sort of talk a little bit about what's the solution then to somebody who's listening and, is struggling with their microbiome? What
Yeah,
path do we take? And it includes testing, but the right kind of testing.
yeah, because I would test these days every single one of my patients, with the odd exception, would get a microbiome
Yeah.
assessment done because I want to see what. And they do a stool transit time, and if I
Mhm.
suspect leaky gut or if they have a disease that's associated with leaky gut, we will always test leaky gut
Yeah.
at the very beginning. I'm like, let's get that data. I might do other
Mhm.
tests too, depending on what else is going on for them, obviously.
Yeah.
But those ones are pretty core because they answer. There's three things. I think those three things are absolutely pivotal for everybody's health: it's gut integrity, gut transit time, microbiome composition. But yeah, microbiome composition, we do have a range of tests available. And as someone like I've been a clinician for nearly 25 years now,
Wow.
and working in the gut health realm, because my honors degree and PhD were around dysbiosis, how we could change the microbiome in using prebiotics, probiotics, and herbs. And that started in 2000. And I even started my literature review for my thesis 25 years ago, today, around this
Wow.
time.
Oh, really?
So yeah, so a long time. And
Yeah.
it's been interesting seeing how testing has changed.
Yeah.
Like what we had access to back in the late 90s, early 2000s were the classic CDSAs or CSAs, comprehensive stool analyses, where you'd look at four
Yeah.
four different types of bacteria, maybe five,
Yeah.
that show up on your stool test. And then that morphed soonish to, I think the first GI effects came out and they had 12. It's like, oh my God, we can see 12 different species of bacteria. That's beeps better than four.
Mhm.
Um, but given that, that we can have 150, 200, 300 species in people's guts, it's a pretty small shot of the ecosystem that we had from that. And patients were paying $800 a pop for those tests back in the day.
Mm.
$800 to see 12 bacteria numbers.
Yeah.
And so,
Jeez.
yeah.
Yeah.
And then as technology evolved and became cheaper, the stuff they
Mhm.
were using in research circles started trickling down to patients and practitioners. And that resulted in labs like Ubiome, which was the first direct to consumer or clinician tests that use 16S DNA-based technology. And that allowed us to see the entirety of the ecosystem, all the different bacterial species there in their relative amounts for about $100. Sometimes $50 a pop. It
Wow.
was a treat for someone
Yeah.
that had a microbiome nerd to like, oh wow, we can see everything that's bloody there and
Yeah.
not break my patient's bank. And we could do
Yeah.
follow-up tests to see what
Mhm.
changes. It's hard to justify that when it's $800 a pop
Yeah.
to do follow up after 3 months.
Yeah.
Sometimes you have to, depending on the condition, people you're treating,
Sure.
et cetera. But now it became like available for everybody. It's like
Mhm.
microbiome assessment, good quality see the whole picture. And then that sort of shifted to, so we still have access to some 16S tests that are not Ubiome. I think they're doing some dodgy stuff with insurance companies to get
Oh,
double payments, apparently.
oh
But
no.
the technology itself was good and the results were
Okay.
accurate. It's just that they had some
Mhm.
business practices that sounded a little
Well,
bit
questionable.
less good. Yeah. Um, yeah, and that would be like labs like Ombre and Vitract or Biomsite in the UK are ones that use 16S technology. And there's other ones that use probably the optimal way of assessing it was it's called shotgun metagenomic sequencing, where they can look at not just the bacterial component, but fungi and protozoal from that too. And again, you get to see its entirety. Now,
Mhm.
in between that time, we were using scientists were using PCR. PCR is still used for certain things in microbiology world and always will be because it's very good at spotting things at very low numbers.
Right.
But the tests that we have access to as clinicians that are using PCR, many of them, not all, many of them give you a pretty small snapshot of the entirety of the ecosystem. That's one of their drawbacks. The drawbacks is they can't see everything. Yeah. You,
Mhm.
you don't get this comprehensive view and relative proportions of things, and which is,
Mhm.
I think, imperative. We want to know about diversity, want to know about species richness, genus richness. Those
Mhm.
things require either 16S or shotgun sequencing to see. Yeah.
Mhm.
PCR tests can't do that because they don't see everything. They only see what those little things that they're looking for, and they can vary with that too. Like some will have a longer wider range, and some will have a smaller range
Mhm.
on PCR testing. So like Doctors Data GI 360 has got a pretty comprehensive, like quite a good coverage.
Mhm.
Vibrant Zoomer's got a pretty decent coverage too, and then you've got other ones that have a much smaller range.
Mhm.
And some of these I refer to as sort of pathogen deep dives, that they've got a
Yeah.
whole 4 pages of pathogens, but like 9 different types of beneficial bacteria listed there. And even then, they might have Bacteroides fragilis, which is one species of bacteria which is problematic, and I want to know about it, but it ignores the other 21 species of Bacteroides that I really want to know about too,
Yeah.
which is really challenging if I can't see them, or microbes like Elastipes, which is another one that's definitely problematic and overgrown in many Western guts, or the main bile-eating microbe that is commonly overgrown in Westerners is called Bilophila.
Yeah.
It's bile-loving. That's what the name comes from.
Mhm.
It thrives on high saturated fat diets. But if your test can't see Bilophila,
Yeah.
you do not know it exists. And it doesn't,
Yeah.
and it means you don't know that this hydrogen sulfide gas producer who thrives on high fat, saturated fat diets is there and causing your patient harm.
Yeah.
So I think there's some major issues with some of the PCR tests, which for me means I would not use them in practice, because I really want, we know that diversity is important. We know that richness is important. We know that Bilophila is important. Having a broader view of the species breakdown is
And the
important.
metabolites
And
too.
metabolites too.
Yeah. You can't see that on PCR, right?
No. Yeah.
Yeah.
So I really, really strongly teach
Mhm.
and urge
Mhm.
clinicians to ensure that we look at the entirety. Like, there are
Yeah.
still some lovely bits on a CSA test that looks at stool pH and short fatty acid levels and calprotectin, lactoferrin. I love those bits. I do. They're
Yeah.
helpful to fit in with another test that will give us the entirety of the ecosystem.
Yeah, for sure. Thank you. That was a great explanation. And I feel like we could talk forever, but we've got to wrap things up,
Cool.
and but basically, just to sort of wrap it up, I guess, just in a nutshell, how do you like to work with the microbiome? Obviously, food is pivotal, right?
Yeah.
But then you also use other tools. What are your main tools when it comes to the microbiome?
Yeah. So I think you're spot on. Diet
Yeah.
is key, but I use a lot of prebiotics too. Yeah. And prebiotics is one of those terms that's immensely misunderstood and misapplied. So people are like, oh, any fiber is a prebiotic. It's not.
It's not.
Prebiotics are selectively fermented and encourage the growth of one or limited number of beneficial microbes. And that's clearly what they do. You can, if someone's low in bifidobacteria, I can give them a prebiotic that feeds bifidobacteria, and you see it go up very, very clearly. Now, if we had them eat just a range of other fibers, you'll feed a range of microbes, which isn't a bad thing at all. It just is a different thing.
Sure.
So often when we're working on ecosystems, we're increasing the diversity of someone's diet. We're having a wide range of fiber types, totally a wide range of colors. We get lots of polyphenols to feed good bacteria, all that. But we're using tools specifically target, their bifidobacteria is low, their Faecalibacterium is low, their Akkermansia is low. Let's feed them. And these tools we can use specifically feed them like a fertilizer for those that generally only those bacteria can use, and their populations go up very, very clearly. And one of the added bonuses we often get is a decrease of pathogens and pathobionts too. So the bacteria that we'd see as more harmful, more pro-inflammatory, go down with prebiotic use too. And you see this clearly on stool testing and in the research. And that's why I love prebiotics so much, because they have that capacity to be selective, that they bring down levels of bad bacteria, to be very short about it, and increase levels of beneficial bacteria quite clearly. So prebiotics in diet are huge. I do use herbs for certain types of overgrowth in certain amounts too.
But you don't use, to be very specific, you're not a fan of these enteric-coated essential oils. You use tinctures because they're less damaging to the microbiome.
Yes. Yeah. And I think because my thesis was around, my honors thesis that I wrote in 2000, I had like huge, really thick, most of it was about the wonders of the microbiome.
Yeah.
It's like this, how wonderful, and that was back then, what have we learned since then?
Yes. Yeah.
It was, and we had this idea that maybe herbs could cause, because all these herbs can kill bacteria, bad bacteria in test tube studies, etc. So could they harm beneficial bacteria? So one of the research projects I did as part of my PhD was doing some microbiology work in the lab, going, okay, let's put some of these herbs on these bacteria and see whether our good bacteria get killed by some of our herbs too. And we found it did. Not like some things were selective, like garlic was quite selective, great. But we used oregano or oregano oil, and it killed your bifidobacteria immensely well. Berberine, killed bifidobacteria immensely well. Your lactobacilli were generally okay, but the bifidobacteria were smashed by it. Even at concentrations that would harm bad bacteria also harmed your good bacteria. And that to me was probably maybe 2001, 2002, we did that microbiology work. So it's always been in my mind that herbs can cause harm if they're not chosen well, and in the wrong form. Because, oregano, I think unless you're a herbalist, sometimes the fine nuances of
Mhm.
herbal products can
Oh, yeah.
not really be on your radar. But
It's
you have
complex.
like
Yeah.
oregano that we make in the tea.
Mhm.
Oregano we take as a tincture.
Mhm.
Oregano we take as an essential oil. Let's
Mhm.
just say there's 3 different oregano type preparations. The essential oil just takes out the really the volatile components that they get from steam. That's it, leaves everything else behind. And it turns out that those volatile bits are immensely antimicrobial, but they also kill off good bacteria. If
Mhm.
you use tea, tea
Mhm.
pulls out a range of polyphenols from the
Right.
oregano and pulls out a little bit of the volatile components, and it is
Mhm.
very selective. Yeah,
Wow.
not nowhere as potent, but very
Huh.
selective. Yeah, and then the tincture is in between. Because if a
Right.
tincture we're using a fair bit alcohol, alcohol pulls out those volatile, but we're also getting the polyphenols. We get the best of both worlds with a
Wow.
tincture, but at far lower um, broadness in that
Yeah.
it still maintains its selective nature unless you go really high with the doses, in which case it's
Amazing.
harmful. And it's just sometimes knowing those nuances, like, okay, we can give the herb like this, and we
Mhm.
can get the benefits of them without any of the negative drawbacks like you get
Yeah.
with the terracotta essential oils, because it's a ton, like a lot of oregano goes into making a few drops of essential
Yeah.
oil, to give
Yeah.
some context on that.
Yeah.
And then the other compound that I'm very cautious around is berberine, and
Right.
that grew originally out of my research where I saw it kill bacteria on my petri dishes. I can't just unsee that. It's like, whoa, look at that. Garlic didn't do that. A bunch
Yeah.
of things didn't do that, but
Yeah.
berberine did.
And so many people
Um,
are taking berberine these days for
yeah,
blood sugar, metabolic
yeah.
health.
And listen, the research is clear. It does do those things. It's just
Sure.
that it
It's
also
damage to the
harms the
microbiome.
microbiome with longer term use. Yeah,
And you
like,
already said that the microbiome supports metabolic health. So what's the better
yes.
option? Take berberine or support the microbiome?
Yes, I know.
Yeah.
I hear you. And there's different ways to achieve like you can improve blood sugar control by taking a prebiotic.
Yeah,
Okay, and then
sure.
you get a
Yes.
win-win situation. Yeah,
Yeah.
and you can take St. Mary's thistle improves blood sugar control. That
All
doesn't have
right.
the killing effects. Nigella sativa black seed
Mhm.
improves blood sugar control and cholesterol levels and doesn't have the metabolic harm that you get with
Yeah.
berberine. We have other tools that have
Mhm.
lots of randomized controlled trials showing that they work,
Yeah.
that don't have the microbiome harm that we get with
Yeah.
berberine. So for me, it's like, why
Yeah.
go
Why?
there?
Exactly.
Listen, I've got we talked before, and I'm dealing with the dental abscess this morning.
Mhm.
I'm taking a berberine-containing herb
Yeah.
right now to treat this dental abscess, and I will
Right.
do so for 10 days. And these
Yeah.
herbs that contain berberine were used as antimicrobials for thousands of years, and they
Mhm.
were used for short-term use. The
Mhm.
idea of going, let's take them daily for years
Yeah.
is immensely novel and goes
Yeah.
against how they were used for thousands
Yeah.
of years.
Yeah.
And the traditional literature, if you delve into it, is like, don't take these for long-term use because
Yeah.
they will
Right.
cause harm. That
Yeah.
they're just appropriate for short-term use, long-term harm, harms the gut. From a TCM
Mhm.
perspective, it harms the gut. And I
Wow.
think, well, that's true. They were spot on. They knew it. They were able to
Mhm.
observe that thousands of years ago,
Isn't that
that these things
amazing?
are right in the right time, the right dose. They're
Mhm.
wonderful tools, but too much is
Mhm.
problematic.
Mm.
And I think what we know now from looking at the research around long-term use of berberine, and it's sadly not very well reported in
Mhm.
the blogosphere, you
Yeah.
get blooms of harmful bacteria and you
Yeah.
get massive reductions in bifidobacteria, like I saw in my petri dishes, but also you're across the board in a range of butyrate producing species. So healthful
Mm.
anti-inflammatory species go down.
Oh,
You have these blooms of Bacteroides and a range of, you get more E. coli, more Citrobacter, more Enterobacter, more Klebsiella.
oh,
These all
gee.
bloom with
Yeah.
long-term use of berberine, which is kind of crazy because
Crazy.
people are thinking the short term it can suppress those things, and sometimes it can. But I think in the longer term, you get these growth of those bacteria, including and also fusobacteria, which is one we associate with breast cancer, colorectal cancer. It's a really nasty
Mm.
bacteria I don't want more of, and berberine
Yeah.
causes you to have more. So it's just like, I
Oh,
think
that
we
is
just
such an
have to
important
really
point.
rethink tools that we're using
Yeah.
for metabolic health. Never mind the fact that I think if we don't do lifestyle and dietary work and
Mhm.
just go, hey, pop this pill,
Yeah.
we're not treating the cause.
No,
Whether the pill is herbal or pharmaceutical, it's still
exactly.
like
It's wrong
not
mindset.
treating the cause. Yeah.
Exactly. That is very valuable information. Thank you so much for your time. Now, we'll wrap up because we've been talking for a while. Like I said, I reckon we could talk for a lot longer,
Yeah.
but luckily I get to speak with you on Monday.
You
Monday,
do.
can't wait. So why don't you tell the listeners where can they find you? Tell everybody who's listening about Probiotic Advisor, your website, your certifications, your courses. You've got so much out there.
Yeah, we first start off doing. I've been a clinician for I said nearly 25 years, so I still see patients within my practice, the Horlac gut microbiome clinic, and that's kind of
Mhm.
our main focuses are gut and microbiome.
Mhm.
Um, And I've got some colleagues who work with me too, because there's so many people in need of help. And we
Yeah.
need to take out some support to work with these people. Then the Probiotic Advisor is a sort of evidence-based database I started, essentially grew out of my teaching that I was doing in the early 2000s of these paper documents I had about the best research on different probiotics, where to find those probiotic strains. And over a decade, I was updating these paper documents, and they're just getting huge. I had 3 different piles of paper that you have to sort of rearrange. You're like, no, I need to put this into a database. So 2014, we shoved all that into a database that makes prescribing probiotics based on evidence, like clinical trials, easy.
It's amazing.
And where to find it.
database.
So there's that. And then, I've been teaching, microbiome support and gut health, how to treat gut conditions with, naturopathic or functional medicine for a long time. But more recently, it went from having shorter courses to doing, okay, let's do a proper, certification course where we can just do like these 10-week deep dives in these areas. So we have, naturopathic and functional medicine approaches to treating gastrointestinal conditions, where you can have a certified healthy gut practitioner. And I chose that term specifically because our saying is like where the microbiome comes first. It's like we often have numerous ways we could treat a condition, some of which we'll call microbiome harm, some don't. Let's go with those that don't. It sounds a bit like a no-brainer, but it's not how it's generally practiced. So it's really trying to come back to, okay, how can we treat something that actually in a way that supports the microbiome and doesn't harm it? Yeah. And that's the underlying driver of the focus with how we're treating gut conditions that we cover. And then we have a second course, which is becoming advanced microbiome manipulation to become a certified microbiome analyst, because as we kind of alluded to, there's been so much research that's come out in the last 20 some years. It's when I started, I could read every single microbiome paper that was published that year and all beforehand. Like even for honors thesis, I would read every single paper in the microbiome in the 70s, 80s, and 90s up to that point. Now there's like 30,000 papers published a year. I know. So and our advances in knowledge and understanding have expanded so much too. So my focus is trying to essentially create, microbiome literate clinicians who can know what microbiome tests to do, how to interpret them, and how to apply a range of tools to get the best outcomes for the microbiomes. And this will become only more and more pivotal as time goes on. Like, one of the lectures we would have covered earlier this term was around chemotherapy and cancer therapy. And it's now coming out that your microbiome composition can essentially dictate whether you respond to a cancer treatment or not.
Amazing.
It can be the factor that determines whether you survive a cancer diagnosis or not.
Crazy.
That is mind-blowing.
It is.
Again, partly not surprising because of all the stuff around microbiome, but stuff like that is going to shift.
Yeah.
And soon they'll be actually screening people's microbiome before they work out whether they start cancer treatment, what medication they use, how we can modify the microbiome. This is going to become, essentially pivotal in treating a range of conditions that we're seeing in practice. So there's a need for people that are really microbiome literate, and that's been my key passion and focus, is trying to train up those clinicians to take that role, because I see people who don't have that training, who are inadvertently causing harm, and not they're trying to. It's just that they don't have the skill set or understanding to know that what they might be testing, might be ordering, is not the best one, and the tools might be using are not having the best outcomes in the broader looking at for microbiome health.
Thank you. I cannot say enough good things about you and your team and your courses. So we will link to all of that in the show notes. And thank you again so much for your time.
You're very welcome. Lovely to chat. And we could spend hours chatting very easily.
Yes, we could. But I'll see you on Monday.
Yes.
Thank you, Jason. Thanks for listening to the podcast. Make sure you're subscribed and that you're following me on Instagram. I'm at Tara Thorne Health. I would also be forever grateful if you'd leave me a 5-star review, because this helps the podcast reach more women who need this information. And if you're interested in working with me, check the show notes for more information about how you can do that. I look forward to connecting with you again soon. I am not a medical professional, and the information provided in this podcast is for informational and entertainment purposes only. I do not have access to your individual medical history or circumstances, so the content discussed here should not be considered as medical advice. Before making any changes to your diet, lifestyle, or considering the use of supplements, please consult with a qualified healthcare professional or your doctor to ensure it's safe and appropriate for your specific situation. Any decisions you make based on the content of this podcast are at your own discretion and risk. Thank you for tuning in.